So it's my pleasure to introduce our guest speaker for the morning, and it's Dr. Jonathan Ellen. So before I sort of go over quickly the highlights of Dr. Ellen's career, I also want to say that he is a pediatrician by training and focused on adolescent medicine and a strong interest in sexual health. And I think one of the key reasons that it's so fabulous to have him is he's no stranger to San Francisco, having done a portion of his training here and also being very involved in trying to address some of the adolescent sexual health disparities that Kyle showed us this morning. So not only does he have an academic knowledge and interest, he has a real commitment to improving health of adolescents around the world, basically, but he has done work in San Francisco and knows some of the issues we face. So it's really great to have him here. Dr. Ellen completed medical school at Temple University and went on to residency at the Children's Hospital of Philadelphia, CHOP, and then fellowship was here in San Francisco in adolescent medicine at UCSF. He also has done training, postgraduate training in STD, both at the San Francisco Department of Public Health and at CDC. And he's currently the Vice Dean at Johns Hopkins School of Medicine. And he is also, he's not exactly bi-coastal, but he's up and down the East Coast because he is now at All Children's Hospital in St. Petersburg, Florida. It's affiliated now with Johns Hopkins. That's my neck of the woods where I grew up. But his family's still residing in Baltimore, so he is going between St. Petersburg, Florida and Baltimore on a regular basis. And we're extremely fortunate to have him sort of detour out west to see us and talk with us this morning. So thanks very much, John, for coming.
This is my clicker.
And this is the laser pointer for puberty.
Got it. All right, good morning, good afternoon almost. This has been actually really wonderful. I love coming to updates because then I get updated, and I have a little bit of an attention deficit disorder going in myself, and when I can sit and pay this much attention, I know you're really in for a treat. So I've really enjoyed the last speeches, and I always love watching Kyle talk. So, and you have to realize the epidemiology in this city does not look like the epidemiology anywhere else in the country. So when I show you slides, Kyle is not lying. It's just different cities and different data. I got involved in adolescent health back in around 91. I came to San Francisco, and it turned out, for reasons that we were talking about last night, and many of which are very unfortunate, the amount of syphilis that we were seeing, particularly in MSM, the amount of rectal gonorrhea we're seeing was very low in the mid-90s. And so we were actually able to divert a lot of resources into adolescent public health work. We haven't been able to replicate that now until recently, where there's been a new priority placed back on teenagers as a special population. But prior to that, we had an opportunity. If some of you look at the old original patient interview form, Charlotte Ken and I played around with it in 95, 96. I don't know what the most recent one looks like. But if you saw, we started putting places on it, and we started putting all these different ways of trying to find, and what I'll refer to as the networks, where disease is being transmitted. And that came out of working very closely with the DIS and working very hard on trying to figure out how we could actually stop infection in teenagers. And I think it's a strange way to look at it, but the concept of screening and treating and screening and treating and screening and treating, which we've done a lot of discussion about today, is even different than harm reduction. It goes even further down. We're just accepting the fact that it's disease, and when people say, why is there more disease, we sort of throw up our hands and say it's endemic and it's just going to keep happening. Well, I try to, and I'm not, and I live in a very Pollyanna world, and I still believe that adolescent sexuality is not necessary and sufficient for STIs. Teenagers who are adult, who are responsible, who are mature, who are engaged in sexuality don't need to be getting sexually transmitted infections. And skin color doesn't make you get sexually transmitted infections. When you start with those two concepts, you've really got to start trying to change a lot of people's minds about sexually transmitted infections, because then we end up starting to say, well, maybe this should not all just be about screening, and treating. And it shouldn't all just be about having individuals learn to put on a condom, because if they don't, they have some moral failing. And what we're really talking about is starting to look at, well, how is disease being transmitted? And I've spent probably the last 15 years trying to understanding, but now trying to give empirical evidence that what you all know, it's who people have sex with and where they're having sex, that probably has more to do with whether they're getting infected or not. And that's kind of how we got into the community model, because if that's what you believe is going on, you have to leave the clinics, and you have to go out into the community, and you have to work with your community partners, and you have to keep trying to figure out ways to get into those transmission networks and find the way the diseases are being transmitted and interrupt that. And I think we've tried a lot of different things. You're still trying many of them. Jackie, who's walking in and out of the door in the back, and I were working on it for a while together. Alonzo, who came in, was part of that. The Youthy Project was part of that. All of these were attempts to try to reach out and figure out ways to interrupt transmission, and we still haven't found the answer yet, but I think what the issue becomes from a policy standpoint is to make sure that along with the efforts that we're putting into screening and adequate treatment, we also have to be thinking about interrupting transmission, and we have to be thoughtful that it is actually possible and doable without necessarily infringing on everybody's human rights. So I think it's a real struggle, but I think it's what makes it fun to be engaged in public health. So that was my whole talk. Now I'll give you the slides that go with it. This is, and again, you get a little bit of a benefit. I'm going to go over the national data on the epidemiology of sexually transmitted infections. It's going to look a little bit different than Kyle's, again, because San Francisco is very unique. One of the problems that we suffer is that you see an overabundance of publications that come out of San Francisco and Seattle, and the world does not look like San Francisco and Seattle. Maybe the rest of us are busy fighting, bigger problems than you guys are, but I actually think it has a lot to do with the culture of the cities. But the rest of the, particularly in the Northeast and parts of the South, our epidemics look a little different. Our nature of transmission looks a lot different. I'm going to do a real quick touch on adolescent development and puberty, just so I give you your money's worth. A little bit on adolescent sexual behavior, what we know, particularly around in-school youth right now, just so you have some context of that. A little bit on adolescents and condom use, and then more on the disparities issue as you start to think about what we need to do to stop transmission. So this is, when Kyle said there's a lot of different ways to show age slides, Kyle had his version. This is the CDC's version. The key to this one is sort of looking at, it's Kyle's slide turned on its side. So each one of these lines sticking out to the right or the left represent an age group, and the further they stick out, the higher the rates of disease. Obviously, you see that the female rates are higher than the male rates. Now, the question that comes up, and I think the question that came up when Kyle shows you adolescent slides and he shows a disparity between men and women, part of that may be detection. And part of that may be the fact that the male partners are older, and so they're not falling into his category of adults. So if you're talking about heterosexual transmission of gonorrhea and chlamydia to young women and adolescents, which Kyle was showing you, which went from 14 to 20, if the partners are 21 and older, they're not going to fall in his data, and he's going to show an even greater discrepancy. If you look at this particular slide for gonorrhea, and you were to look at 15 to 19-year-olds, you see 568 per 100,000 is the rate for women, versus 250 per 100,000 for men. And then when you get to the older age group, you can see the discrepancy in gender is not as great, which sort of signifies either there's spontaneous disease transmission, or you probably are getting some type of cross-age mixing going on with regard to transmission. Chlamydia, again, same issue because of the issues around detection and symptomatology. You probably are seeing a difference in the overall rates of disease, and you can see here that on the male side, which is your left, I'm really bad with sides. If I was standing here, it's the right. If I'm looking at it, it's the left. You basically find yourself seeing numbers that are much smaller than the female sides because we're doing much better on the screening of the women. I'm going to try to hesitate from getting into a long discussion about male screening, even though it's another one of Kyle did a really nice job of answering it. But I think it's a resource allocation answer to many of these discussions. And I'll just say this as my chance because I have a microphone and an editorial. A lot of these discussions, when you get down to it, you have people in a room with the same data, and someone says, I want to allocate resources to this. I don't want to allocate resources to this. If there was the money that came down to Kyle from heaven and we were going to share it with everybody, there's a lot more we would do because we'd stop worrying about cost effectiveness. One life would be worth, and one case would be worth everything to us. The problem is it's not. We don't have those kind of resources, so we do make very difficult choices. In this city, for example, we do a lot of screening. Again, from MSM, the question becomes, in downstream, is there real good cost-effectiveness data for that? And there really is not, but it is a mandate of the city. So you sort of get down to, there's politics, there's policy, and there's economics, and they all come into play this. I would say that male screening could play a role if you're talking about interrupting transmission, but it's a very costly strategy, and that's what I think Kyle was trying to point out. So nonetheless, here's what we aren't doing a lot of screening in men, and this is why you see these major differences, because the women are getting infected by men. This is just to show you what happens when you're not just using a surveillance system, but you're actually doing a sentinel screening system, where you have a population of women coming into family planning clinics, and you screen them. And everybody, you have a denominator and a numerator, because on the other data, all we really had were the positive tests put over the population, which is what Kyle was showing you before. This is data where you actually have the negative test and the positive test in the denominator, and the positive test in the numerator. And you can get rates that, to say, walking into a family planning clinic funded through the Infertility Project, you see rates that run between 5 and 6%. So chlamydia is a real burden of disease. It's not just an artifact of who we test and how we report the infection. You can see if you come into a population that's closed, you'll get a particularly constant rate. Syphilis, this is the one that I think really varies around the country more than almost anything else in terms of what age populations and who's getting infected. We see a very low rate in women around the country. In the adolescent age group, you see 3.3 cases. And then we see it going up to women a little bit higher nationally. And then if you look on the other side, because of the epidemic in MSM, you see a much higher rate among men than you see among women. The age issue really used to stand out even more dramatically over the years, that we used to see very few cases among 15 to 19-year-olds in general, particularly women. We've seen little sporadic outbreaks over time. Kyle was in San Francisco when we were trying to figure out why we were seeing cases in young women. I still don't know the exact answer, but it's the big concern I have, is that it'll drop into that population. And that's both a childbearing population, where you start to make congenital syphilis an issue, as well as it's a sign of real vulnerability of a population. I'm going to actually skip this in the interest of time, but just to show you that the peak ages of getting HPV do happen to still be in the young adult adolescent period. Moving into the sexual behavior data, I'm going to report out on the YRBS, which is Youth Risk Behavior Survey. It's very difficult to have good data on less than 18-year-olds in this country in terms of their sexual behavior. We would love to have household samples mixed with school samples and put it all together and get a really nice descriptor of what's going on. We don't have that. What we have is a biannual, every other year, survey that goes on in selected schools around the country that are meant to be relatively representative of what's going on in in-school youth, and I just want to keep making sure that's true, that it's in-school youth, but gives you a sense of what's happening from a sexual behavioral surveillance standpoint. So this is with a survey where we report that actually the number of adolescents who are high school students who engage in sex is going up or down. This is the one where we say condoms have been going up or down. All of these data are available on the websites. They keep them up every other year. They put them out in these slide sets, so obviously I didn't make this beautiful slide, but I get to show it to you. And what you can see here is, and the real main take-home on this is, first of all, you see that the percentage of high school students who ever had sexual intercourse, so that could be once. We don't differentiate between choice and whether it's been forced. And we also, does not mean in terms of how many of these young people have actually had sex in the last 3 months, probably closer to 30 or 40% have. So what you really are not talking about is regular ongoing sexual behavior, but an intermittent kind of phenomenon in many cases. But nonetheless, you see about 45%, and this is all high school students, obviously at 9th graders. Fewer, and then 12th graders much more. And you see here that in terms of sexual behavior among adolescents, we do see what would be a difference by race, ethnicity, at least by report on the piece of paper that the students are filling out. So it's about 65% versus 50%. This is just another way of looking at the trend. The argument has been that since 1991, we've seen a decrease in the percentage of youth who report ever having had sex. I don't think it's gone down about from 54 to 46, so it's about 8 points. And I think what we probably believe is that there has been messages gotten out there. May have just been a temporal trend. I have no idea whether the fact that we've been pushing prevention messages out there, I definitely don't think it's the abstinence-only issues. But I do think the concept that we have been talking about transmission and and other kinds of concerns in HIV and STIs. It all gets put together, and you end up seeing the same kind of trend. And that people attribute this trend to the decrease in teen pregnancy rates. So what we've just seen is a decrease in sexuality or sexual intercourse, not necessarily sexuality among adolescents. And then you get to the rise in the discussions around oral sex in teenagers, because you then sort of start adding up that adolescent sexuality hasn't necessarily changed. It's just what they may be doing that's changing. And then this has to do with number of sex partners. And of all the variables that I really point to, this is the one that probably puts youth at the greatest risk. If it's what their partner's doing and it's how many partners they have, that probably makes them at the most vulnerability. The more exposures, it's not about promiscuity, it's about the fact that you get more exposures to somebody, or likelihood of being exposed to somebody who's infected, and that's really the model that we're looking at. And as you can see here, that you do see a disparity or a discrepancy or difference by race, ethnicity, if you look all the way over to the side. And condom use, which is the last sort of preventive measure I wanted to talk about. You can see, and I don't know if I have it on the next slide, but you can see that condom use is relatively high. And I could go into a long discussion. It depends on who you're asking them if they use the condom with. We see relatively rates in the 70%, 75% if we're talking about casual sex. If we're talking about main partner sex, the numbers can drop as low as 20%. So, and that was sort of probably, like many of you know that from doing any clinical work or talking to any teenager, that with a main partner, people are not particularly compelled or feel particularly motivated to use condoms with main partners unless they think it's their best birth control method. But people are usually not as worried about, particularly among teenagers, around sexually transmitted diseases and their main partners. Now, that may have nothing to do with reality, but it is the way they sort of put themselves together and put themselves at risk. And this is just to show that we have, the same way I told you, there is a sense that there's been some movements over time in the rates of youth who have engaged in sexual intercourse. Now we also see an increased number that have used condoms over the same time period. So in some ways you would expect there to be lower rates of gonorrhea and chlamydia in this group. We still see pretty high rates of chlamydia, and they seem to keep going up. So this is probably real. There's probably an increase in condom use. I think the normalization, as much as we talk about normalizing stigma, we've come a long way since 1985, when you had to be in the military for anyone to ever think you needed to put a condom on. So I would say that we have made, and your beautiful sign that was on the mailbox, about the penicillin. But other than that, I think we have made some real inroads in that respect. So I think people are taking more preventive behavior. I think adolescents have heard the message. I think, unfortunately, there are youth who are being kept away from this kind of information, and I think that causes problems. And we've shown that if you keep them away from that information, when they finally engage in sexual behavior, they are not educated and they don't protect themselves. So there is a lot of, I think, of policy work that we've done that I think has been positive with regard to making youth safer when they do engage in sex and sexuality. I do think we still need to talk about STIs and figure out ways to stop them. So this is going to be sort of the take-home money shot of my talk. It's coming in the next several slides. And this has to do with why this was a study that we did in 1994 or 5. I was really getting tired of people saying, if you're black, you get STIs. And if you go to enough talks, you'll hear, if people don't know what else to do, you're going to dance in the back. Well, yeah, and if people can't find anything else significant, you can always show that black race gets you infected. So I think that the real take-home message, though, is that we really did this study, and it's actually been replicated a lot of times, and with even better approaches than we utilized. But the question was, if you took those little differences that I showed you around sexual behaviors, and you adjusted people's likelihood of reporting that they've ever been infected by a sexually transmitted infection, and you adjusted for the differences in sexual behavior that occurred by race, ethnicity, would the report of a sexually transmitted disease go away? And if it was all due to behavioral differences, so you would expect that if I adjusted for that, there'd be no differences left between race, ethnicity, and disease. And now, I'm just going to say this up front now, and people's argument, well, if it doesn't go away, does that mean that it's a genetic factor? And the thing I'm going to say, and I have laboratory people here, and I have ID people here, every one of these infections happens a completely different way. You may get them through the same process, but they all have completely different pathophysiology. It's almost impossible to tell any type of biologic story that accounts for these kind of disparities and discrepancies. The only thing you can really point to is something that is common And I'm going to show you it's not behavioral difference. It's something common, perhaps about place, perhaps about where people live, and perhaps about how society has created where people live and how that affects transmission. We took what was a version of the YRBS, which is a survey, and they had been, instead of just being done for in-school youth, it was done with household samples, so it had in-school and out-of-school youth. It was a representative sample, and again, this is an old study, but it's been replicated in the last 2 years. So what I'm showing you is my simple slides without having to make new ones, but it does has been borne out since. And basically what we see is that if you ask people what the relative risk of reporting having been infected by a sexually transmitted disease, you're 3 times more likely to report it if you're African American than anyone else. So the self-reported rate of sexually transmitted diseases is high in terms of the disparities, and it goes with the surveillance data that Kyle showed and that I've showed before. When you adjust for sexual behaviors, which I said to you before, if it goes away, it has something to do with just the fact there's more sex among black youth, and that's the problem. But if that's not the problem, then it shouldn't go away, and it didn't go away. In this case, it actually went up. There's some weird sort of interaction terms that got in the way, but what this really highlighted for me, and I highlighted in a lot of other work we've done at the time, was that there's something different going on with regard to networks, about where people live and what kind of networks that exist. I'm not going to go into a long discussion, but it all comes back to, at the origins of what I'm about to show you, is that that separate and equal never existed, never can exist, and the concept that you can create separate communities and have the same risks in the same communities does not happen. There's no such thing as separate but equal. And because there's not, and when you create segregated communities, you create different networks and they have different properties. And I think when you start to think about what kind of properties were created in different networks through the different kinds of segregation, particularly in the South, and particularly in the Northeast, where we see these disparities in even broader strokes than you see anywhere else, you will start to come to the idea that we created different kinds of networks in these different kinds of communities. So this is San Francisco, and this shows you, I don't think Kyle made this one. I could have just likely thrown up a Kyle map because his maps look like this too. In fact, this is one that was made by Jackie Jennings, who was a contemporary of Kyle's, and the bright red areas are the high gonorrhea areas. And what's really even more upsetting about this, and first of all I'll use the pointer, Hopkins sits here, University of Maryland sits right there. So if you want, and there's an STD clinic sitting right here, and there's an STD clinic sitting right up here. So basically, you can't say there's not care available to that community. Now, there may not be care by the community, by the hospitals for the community, but you can't say there's not clinical services that are available. And most of these clinical places will see patients regardless of their insurance. So really what's going on here is there's something else going on. And the hospitals and the universities are not dealing with it. So what we're really thinking about is there's something about, like I said, separate but unequal, and you get into the issues of structural determinants of sexually transmitted infections, and you start to talk about what is going on in certain communities that create certain networks. And again, I always like to give my punchline first and then go through it. You can imagine when you segregate a community and you then segregate poverty and by race ethnicity, you start to put young people in context with certain parts of the community that other youth may not be exposed to. So if drug dealing is in a particular part of a community and you are also can't go anywhere else but live near that drug dealing, whatever is being sort of created by those drug dealing networks, your children living in that community are going to be exposed to. That's a different experience than somebody who can say, well, I want to get in my car and move my family 20 miles away and buy a big house, or I can live wherever I wanted to live. And now remember, this is historical. Maybe it's, I think that people have a little more freedom on movement, but you go back to one of the things that goes back to this last slide, one of the things that Kyle and I know about the slide is that this line right here is called North Avenue. You couldn't buy a house if you were black above North Avenue in 1972. So the concept that this is where the clusters are and the water's here. So there's water here. So there's a water line here, and there's a demarcation line that banks would not let you live above here. You can see how the world got segregated, and you can see what the ways you can imagine that the structural features of these communities put youth at risk, because you could not, if you wanted to, move your family away from something that was a problem in your community. So the way that we sort of had to prove, again, this is all proving what you all know already, and some people say, well, then why are you bothering? But there are some people that need to see the data, and when you see the data, it's compelling. And this was a study done by Jackie Jennings, who did the last one. And what's really, the point of this particular work that we were doing was trying to show that where you live, independent of your behavior, and independent of anything else, but the prevalence of disease where you lived was probably the biggest predictor of whether you got infected. All sounds obvious, but had never been done, and it needed to be done. So we did a household study in Baltimore. I've done 2 big household studies. One is in Bayview here, and one is in Baltimore. And we went there. We surveyed youth in the houses. We used 15 to 24-year-olds. Went in the house, got permission from the parents, screened the youth for sexually transmitted infections and HIV, and also looked at their sexual behaviors, and then we were able to put all that together into a model. 15 to 24-year-olds English speaking, and in Baltimore that there was a very small population of Spanish only speaking families. It's changed since, but at the time we were doing the study. And we did screening, and I'm going to jump to the point of this slide right here, just to keep us on time. And what you see here is that after you adjust, and what the purpose of the slide is say, after you adjust for whether somebody is basically on, let me get to this slide here. Once you adjust for the age of somebody, they're young or old, their gender, their age of their maternal education, the number of sex partners they've had, the condom use, last sex, all the things we think make an individual at risk, where they live, the median, the gonorrhea rate of their neighborhood, which is the bottom here. I'm sorry, it's down at the bottom, but it's the bottom. I should raise the whole slide up. Is the biggest risk factor for getting infected. So where you live, the rate of disease in your community, after you account for your own behaviors, after you account for how well educated your family is, you're still at risk. So some youth, where they're born, geography is destiny, and the issue and the point being that we start to say geography matters. I have one more example which came out of Bayview. So we did a study, we all were engaged, I think Jackie was involved with it years ago, where we said, we've been doing work in Bayview, and we said, let's go back and see if certain communities in Bayview, and we actually, the whole southern part of the city is what we really were sort of focused on, because there were still the towers, Geneva Towers were still up at the time, I think. And so we sort of spread all around that whole southern rim of the city. And what we were looking for is the networks of adolescents and their sexual networks, and see if we could show that the sexual networks actually had an impact and were different by different communities. So we interviewed adolescents in the house, we went to their friends, and then we went to their sex partners, and then we went to their sex partners. So we just interviewed everybody we could get. We had people running all over the city trying to find, we went to the jails, we went anywhere we could find people to try to link together the maps of the networks. And the real question we were trying to find out is whether these network characteristics that youth were experiencing, first of all, were linked to getting sexually transmitted infection, and then do those network characteristics vary by community. And that's getting us back to this whole discussion that where you live is what you get, is the kind of network that you get, and when you decide the kind of network you get, then you decide your likelihood of getting infected. After you adjust for whether you're a big condom user or not, after you adjust for whether you have a lot of sex or not. So we basically collected all this information, and what we came up with was a very simple way of describing what is very complex data. And here we basically say, look, if you're in a mutually monogamous relationship, you're pretty well protected. If you're in a relationship where you don't really know what your partner's doing, okay, you're a little less protected, but you think they're monogamous. And then as you start getting the cases where you have multiple partners, or your partner has multiple partners, which is partner concurrency, all of a sudden you start to run to a place where your risk can get bigger. And what we show here is that as you build these more complex, more interconnected networks, that you start to see an increased risk of being diagnosed with a sexually transmitted disease. So as you go from being in a network that's a situation where you sit in a mutually monogamous relationship to one where you have other partners and your partner has other partners, your risk for getting an infection goes up 6-fold. So now we've established that there's a particular kind of pattern to a network that's pretty intuitive to all of you, but that's associated with getting an infection. The next question is, does that vary by community or by characteristic of the community? So we have disease prevalence where you live matters. We have arguments that it's not about behavior. We have arguments that structure and the nature of a network does matter. And this final study was trying to show that if you looked at census tract exposure, that is what kind of, whether you lived in a very impoverished area or not, and one of the things to know is that if you looked at the census data around, and Kyle will tell you, if you look at even some of these areas where we think of high STDs, we actually do see variation in the SES, or socioeconomic status, of different communities. Single family ownership, different kinds of things actually vary as you go across these different communities. And the question is that are people living in different ones of these kind of communities have different structures to their networks? And what you see is that if you live in an impoverished census block group, which is about 1,000 people in San Francisco, and you adjust for everything else, the likelihood that you're in one of those high-risk sexual networks goes actually, if you don't live in one, the likelihood of not being in one, it's backwards, but the point is, you go up about 4 or 5-fold. The reality is that you get a higher risk network when you live in an impoverished community, and we said if you have a higher risk network, you're more likely to get infected. I can show you very quickly how African Americans have been segregated to these high risk communities, and what you end up with is a very clear starting to be pathway that says these networks really are shaped by the communities. There are contexts in those communities. We've done work since then that started to show that the drug networks sort of drive these kind of sexual networks. And you start putting this all together, you say, okay, we need to figure out a way, and that's sort of really my take-home message, to intervene on transmission in these networks or disrupt these networks, or we'll never be able to stop STIs and sexually transmitted infections in teenagers. All we'll be able to keep doing is screening and treating and screening and treating and screening and treating. And so that's the end of my talk, and thank you.
So we've got about 5 minutes for questions.
Joe.
Hey, John, good talk. So you alluded to drug dealing. What about the war on drugs and the incarceration rate of these young black men?
Yeah.
And what kind of risk is that
So,
for them and the women?
Right. So Joe's talking about, there's a couple things that you have to look at. The question is, what does incarceration, let's sort of take the simple question rather than getting to the whole issue of interdiction and what that does to anybody's behavior. But let's just take the idea of increased incarceration for certain communities, and what does that do to the networks? And one of the arguments that's been put out there is that the creation of these disrupted concurrent networks are created by people being pulled in and out through basically a movement or a migration where people are pulled out of a community, put in jail, come back to the community, go in and out. And what you're basically doing is creating these very disrupted networks, because the ability to have sort of stable relationships, that monogamous relationship, gets disrupted. So whether the cultural acceptance or whether the preference or the cultural values around what I'll say is lots of sexual partners is actually inherent or comes out of this structural thing that Joe's alluded to, which is people being cycled through the penal system, and what happens is disrupting networks and creating, when people move in and out, these very high-risk networks, is the other question. And I think people are trying to put those together. I think there's people doing interventions trying to figure out when people are released from prison, how do you get them back with their main partners without there being lots of concurrency in the in-between. But I think it's a real question, and how that ties to our continued rates of infection, we haven't shown yet. I mean, I think it's intuitive, but it's not been shown.
Did you also look at family units, like divorce, single, like what did you
I did not go down the demography family structure pathway. I probably could have. We could drill down and say, but again, we're looking at, what we have looked at is, do parents affect networks? So, and not so much whether it's single family or not, but does parental involvement in a child's life have any impact on whether their sex partner, whether the child's sex partner has concurrency? And we've shown that that's in fact true, that parents who are more engaged do know their children's sex partners, and they do have a sense, and they somehow moderate the riskiness of the networks. But it's not that simple, though. So we have some data for it, but I don't think I'd go all the way to
I
policy.
just wanted clarification on
Where are
the
you?
2 research questions.
Okay.
You define the networks as the risk increasing by the number of sex partners, and
That they have and their partner has.
right. and you talked about the communities and the risk of, I mean, the possibility of one community having more of those higher risk networks as opposed to another. So are you basically just defining it as communities that suffer from poverty have more sex partners and those kinds of networks?
Well, it's how they connect together, but you could argue that you could say that people have more sex partners, but the reality is there's people on the ground, and so that means I'm having sex with you and you have more sex partners and I have more, and to the extent that I know that, there's a tolerance or there's an acceptance that goes on, and one of the issues around gender ratios and around disruption is people accepting these higher risk structures. So you're right, it does get built up from the fact that you could argue that all this is about number of sex partners and they get together, but it also says something about the fact that people let them get together. So it's not as simple as just saying, well, the culture says more sex partners and therefore everyone will get together, because many people here would not necessarily tolerate infidelity in a relationship, but you start to make trade-offs. And that's the other part of this, is how does that happen in a particular way?
Hey, Jonathan.
Yeah.
Great talk and welcome back.
Thanks.
I have a question for you. Do you have a sense of like a tipping point? Like we all see high-risk teenagers all day long in our clinics and stuff. Like at one point, you've had sex once with one partner, hope you're in love, and that's all going.
Yeah.
But after a while, you start having sex with 2, 3, 4 people.
Right.
Do you have a sense of where that falls?
No, that's actually a good question. No, but I probably am not the right person to ask, because, again, I have a tendency not to look at the individual adolescent and think about what drives them to their behavior. And so I'm not probably the best person for that, and probably I have a blind spot for it, because I am really interested in why these networks get created. And what I'd be more interested in sort of saying is, what does it take for a community? What are the factors in a community that are the tipping point? So I go back to the book, obviously, and start talking about what changes the community, whether it's a policy around drug enforcement, and that tips over the structure. And that's not that there's not, the answer isn't, there should be one, I just don't know it.
All right.
Thank you.
Thank you very much. That was great.